second part of my talk, dear colleagues. And Professor Subramaniam, I'm very happy that he showed his last slide, because my talk will end up with exactly the same slide, but I will start with bacterial vaginosis, and you will see how and why it ends there. This is my disclosure of conflict of interest. So what about vaginal infections in pregnancy? They are very frequent, you know that, and this is the numbers, up to 20% bacterial vaginosis, candidiasis, aerobic vaginitis. So many women in pregnancy do have a bacterial vaginosis or aerobic vaginitis, and many of them don't know that they do have it, because they do not have symptoms very often. This is an example of what we found in our own population. We looked at almost 400 women in pregnancy. None of them had any symptoms of infections. They were pregnant, but you see that they have overall, if we take together bacterial vaginosis and intermediate flora, they are up to 20% of women. Each fifth woman in pregnancy doesn't know that she has vaginal infections. But what should we do about it? Should we just sleep on, or should we care about this issue? Of course, you know that we have to care, because there is an association between the infection and severe complications of pregnancy. These include mainly preterm birth and late miscarriage, but also chorioamnionitis at term birth, postpartum problems such as endomyometritis, or after a cesarean section wound infections. And some of the women, of course, also have symptoms, but it's a minority in pregnancy who have symptoms. And this is the actual paper regarding the cause of preterm birth with association with bacterial vaginosis. And you can see that the relative risk is between twofold and fourfold, depending on the study. That means that those women with bacterial vaginosis in pregnancy have a 2 to 4-fold higher risk of preterm birth. And the reason why they have this risk is not that the anaerobes present in bacterial vaginosis, that they are descending through the cervix. It is an ascending infection, this is right. However, it's not the germs of bacterial vaginosis. The reason is that bacterial vaginosis is a sign that the defense mechanism in the vagina is disturbed. So other germs can go through the cervix, into the uterus, to the membranes, provoking chorioamnionitis, contractions, and also infection of the fetus, of the amniotic liquid, and in the end lead to preterm birth. And what's happening is not that these bacteria themselves produce toxins which lead to preterm birth. It is an indirect effect in terms of that these bacteria lead to inflammation. That means that, and if you have the opportunity to read this nice paper in Science by Roberto Romero, they explains very nicely that it's not the bacteria themselves, it's the host defense mechanism which provokes preterm birth, which is guided by the macrophages in the membranes, leading to a secretion of pro-inflammatory cytokines, including interleukins, TNF-alpha, and then leads to the whole cascade producing prostaglandins and activating the gap junctions in the myometrium, leading to membrane rupture, shortening of the cervix, and also the uterus. But also, it's not only the preterm birth which is the consequence of the inflammation. It's also the damage to the baby, because a baby being having a preterm birth, being born preterm by an inflammation, has a worse prognosis as compared to other causes of preterm birth, like, for example, preeclampsia. And the main consequences of this inflammation in the baby is the chronic lung disease, is the neonatal sepsis, of course, but it's also the neurologic outcome, because this inflammation happens also in the brain. So there is a close correlation between interleukin-6 levels in the baby and in the baby's brain, with the periventricular leukomalacia and the long-term outcome of the cerebral palsy. So that means that the inflammation is the main clue to the damage to these babies. This we have to carry in mind if we go on with the talk now. Now look again, we go back to bacterial vaginosis in preterm labor. We saw that there is a clear high prevalence, that there is a 2 to 4-fold risk for these women because they have a changed host defense. There is an inflammation to the cervix. And this was something we wanted to know. How is the correlation between bacterial vaginosis and cervical length? Because we are used to just measure cervical length and think about it, but why is the cervix shortening? Because the tissue is changing. The collagen is disaggregated, and the reason why the collagen is disaggregated and the cervix becomes soft and short is that there is a change in inflammation in the host defense. And this is correlated to bacterial vaginosis. And this following study, which we have done now already year 2000, we have shown that this correlation is clear. That means in women, and these are all women with preterm labor, in women with normal flora preterm labor, the cervix tends to be longer than in those ones who have bacterial vaginosis. So the bacterial vaginosis itself seemed to provoke a defense mechanism with an inflammation in the cervix leading to a shortening irrespective of the uterine contractions. So there is actually, this study is the proof of this connection between these two. So that means that the bacterial vaginosis is not the bad bacteria in the end. However, it's a change of the ecosystem in the vagina which leads to abnormal inflammation in the cervix and in the end to preterm birth. So that means that we have to do something against bacterial vaginosis if we detect it in early pregnancy. We have different modes of treatment, as you know. We can treat very focused with metronidazole. This is an agent which goes only on anaerobic bacteria. You know that bacterial vaginosis typically has aerobic bacteria. However, there is also other treatments. We can use more broader treatments such as clindamycin, which is a drug which covers anaerobic but also aerobic bacteria, or we can use an agent such as dequalinium chloride, which is a local anti-infective in the vagina, which treats the broadest spectrum. You can see here that's a treatment option in these women we have with bacterial vaginosis. We can use only metronidazole, but then we kill only the anaerobes. We can use broader clindamycin or the dequalinium chloride, which also covers mixed infections and candida infections. This dequalinium chloride is an antimicrobe activity with against atrobopium as well. I don't go into details of this mechanism, but it shows that in vitro it has a MIC, which is a minimal inhibitory capacity of the bacterial growth, which is the same like clindamycin, but is better than the metronidazole in effectiveness. This shows that this drug is improved, has an improved effect against iodine, but it also has an improved effect as compared to clindamycin. If we compare these two drugs, you can see here this is a randomized control single-blind study being performed. Clindamycin vaginal cream versus dequalinium chloride, and these were over 300 women, all with bacterial vaginosis, and you can see what happens, the same effectiveness for both. So the cure rate was the same, around 80%. However, those treated with clindamycin had 8% incidence after treatment of vaginal candidiasis, because it does not cover candida, but fluomycin, which is the trading name of the dequalinium chloride, it covers the whole spectrum, so it covers also the fungus infection, and this dequalinium chloride is also safe during pregnancy. So it's one of the treatments where we can see we have broad spectrum treatment which is safe during pregnancy. But so now why should we use broad spectrum treatment and not metronidazole? Because I suppose you all use metronidazole in PV. But I will tell you after this lecture, you will go home and you don't use it anymore. And I show you why. Okay, so this is a treatment to prevent preterm birth. There's a lot of studies treating bacterial vaginosis and trying to lower the risk of preterm birth. They have been effective, this treatment, in a high-risk population in this study. However, there's another huge study with hundreds and hundreds of patients. There is no effect in the low-risk population, and that's a problem. And then we go to the next study, which was also a big one. They started an early treatment before 16 weeks, not only at 20 weeks, and there they show it's effective. So that means that if you have in early pregnancy bacterial vaginosis and the inflammation has not already changed the cervical structure, you have still the chance to avoid the inflammation and the consequences. So probably, and this we learn of this, probably we need to diagnose and treat it very early, which means at the end of first trimester, beginning of second trimester, certainly before 16 weeks. If you go too late and the inflammation in the cervix is already there, you cannot change this anymore. The second point is here, it's a meta-analysis of all the studies being done with treatment of bacterial vaginosis, and you can see here there's all different results and all different regimens. You can see here's metronidazole, this is clindamycin vaginally, metronidazole orally, clindamycin orally, so it has a different kind of antibiotics. And that was actually the reason why the results of the study were very inhomogeneous. So we don't have really a proof that with antibiotics we can prevent preterm birth. But what has been found is that systemic metronidazole, oral treatment of BV, in some studies increased preterm birth rate in a randomized trial. So why does metronidazole treatment increase preterm birth if used in pregnancy? I think this is clear after what you know now, because you know that metronidazole is only acting on anaerobic bacteria. And if you have a mixed infection, if you have this infection, for example, and this has been shown recently by Gilbert Dondas, that many of the infections is not only bacterial vaginosis, it's not only anaerobic germs, it's a mixed infections, or you have aerobic vaginitis. And this is the proof that in this study he showed that in aerobic vaginitis, this has looked at the prevalence of preterm birth after aerobic vaginitis, and he could show that it's even higher risk of preterm birth as compared to bacterial vaginosis. So it's not only the anaerobes that we have to care for, it's also the aerobe germs. And that's actually what happens in aerobic vaginitis. They have even more inflammation, so the cervical structure changes quicker, even in aerobic vaginitis, and also it therefore leads to preterm birth. And that's something you can diagnose quite easily, as I showed you in this lecture before, also with the microscope. These are the data of this study. So that means in the end, we have two options. Either the woman is pregnant, has a normal flora, a lot of lactobacilli, everything is fine, we don't need to do anything. However, if this flora is abnormal, if there is low number of lactobacilli, we need to care, irrespective if she has aerobic climate with bacterial vaginosis, or if she has aerobic climate with aerobic vaginitis. So all here on the right side, which is red, we need to care and we need to treat. That means, again, we cannot treat only this part. If we treat only this part, we get lost to this one, because you will select, if you suppress the anaerobes, you will select the pathogenic aerobes, which include, for example, streptococci, staphylococci, E. coli, enterococci, etc. And this is the dangerous germ. That's the rationale behind the idea also that metronidazole is not the right treatment in pregnancy against bacterial vaginosis, because you need to have a broader spectrum treatment. And this is also been recognized by the Cochrane meta-analysis, which looked at all the studies and said overall the risk of preterm birth could not be decreased significantly if you take all studies. However, if you take the studies where there was early diagnosis and treatment and also a broad spectrum treatment, there was a 50% reduction of preterm birth. So we need to diagnose and treat early in pregnancy with a broad spectrum antibiotic. I think this is the main take-home message I wanted to tell you, and I come to what's happening in research, and now I come closer to what Professor Subramaniam told you. There is new knowledge about the connection between infections, the microbiome, and the preterm birth. Because of this study. This study looked at healthy women, looked at the microbiome in the placenta, because everybody thinks the placenta is sterile, the fetus is sterile, there is no microbiome. However, this study has proven that this is wrong. It is not true that it is a sterile environment, because they looked at all these placenta, they made 16S ribosomal DNA, whole genomes, shotgun metagenomics. They looked at each and every bacteria there is in the placenta, and they found in the placenta a microbiome. It's not a big one, but there is one. And interestingly, the microbiome was not similar like the vaginal microbiome. You may think it could be similar like that one, but it was more akin to the oral and intestinal microbiome. That means that obviously the placenta, there is some microbes which do not harm. But so they do good. They have eventually a physiologic function in the maintenance of placenta and maintenance of the healthy pregnancy, but we don't know yet. This is very new data. So this finding shows us that the placenta is not sterile in the uterus. There is a rich microbiome. It's largely non-pathogenic commercial microbiota. So it's bacteria which probably provide a healthy microbiome in the uterus and also in the amniotic liquid, and it is akin to the oral cavity. And the interesting point is yet to come, because there is obviously a role of the microbiome in the mother for the development of the fetus, and I explain you why. So the biggest microbiome is in the intestine of the mother, is in the gut. You know that all of you have maybe 1 kilo or more bacteria in your gut. So think about how much metabolome will be produced by these bacteria going through the placenta and having influence to the fetus. It's not only intestinal, it's also the vaginal microbiome, because what is in the vagina produces, all these lactobacilli produce also metabolics, and these metabolomes will come into the bloodstream and also, similar like from the gut, go to the fetus. And so what effect do they have on the fetus development? And this study, and this has shown in the mouse model just recently, this has proven that there is, in fact, an effect of this microbiome in the gut on the development of the immune system. They took sterile mice, and one group there was kept sterile, germ-free, and looked at the offspring, and the other group, they put bacteria in the mice, and they looked what happened. It was commercial bacteria, commensal bacteria, there was no pathogenic bacteria. And they could show that these fetuses, after birth, they developed a healthy immune system, but only if they had bacteria in the mother. So if there is no bacteria in the mother during pregnancy, the fetal immune system cannot develop normally. And this shows you the importance of a healthy biosystem in the intestine, but also in the vagina during pregnancy for a normal immune system in the fetus. This has actually been proven in the mouse model, not yet in humans, but it's very likely that these results will be reproduced in the woman. And then comes again the question of cesarean section. And I always have discussion with the midwives, because the midwives say cesarean section is not good, you should have only vaginal delivery, of course. However, the message that cesarean section leads to sterile baby and it's not good for the development of the immune system probably is not true, because after 4 weeks the whole microbiome in the baby, in the skin, in the intestine, everywhere has completely changed, because it gets the microbiome by the breast milk, by the contact with the mother, by the skin, it suckles on the breast. That's where the microbiome comes after birth. However, the period during pregnancy is not the short time of vaginal delivery of 10 hours or 1 hour or half an hour, but it's 9 months where the immune system is being formed and shaped by the mother's microbiome. I think this is the main message I want to give you, and that's a new view on the importance of the vaginal microbiome during pregnancy. And this is actually the same picture you have seen before. I think it's a very nice review by Andrew McPherson about this connection, and I recommend you to read this. So in the end, take-home message is short. Vaginal infections are very frequent and correlate with severe pregnancy complications. Second is that screening and treatment of abnormal vaginal flora must be done early in pregnancy in all pregnant women, and they can avoid preterm birth and late miscarriage. And if you treat it, you need to have broad-spectrum antibiotic or anti-infective treatment and not metronidazole in pregnancy. Decolenium fluoride, the fluomycin, is one example of a broad-spectrum treatment, and I explained you the new view, the new rationale of the placental and microbiome and the vaginal microbiome for the health of the baby. With this, I'm finished. I thank you very much for your attention. I'm open to